Good. So let's have a look at the interpretation of these SUV maps first. And I will just give also a bit of a broad overview about SUV uptake in different states of consciousness. So when we are in normal, healthy wakefulness, you see that the glucose uptake is 100%, let's say. So it's high, it's throughout the whole cortex and high. If you are brain dead, or if a patient is brain dead, then you see only glucose uptake in the skin surrounding the skull, but you see kind of a black box, right? You don't see any uptake in the brain itself. So this is a patient that is brain dead and cannot recover consciousness. Then when we look at the healthy subject under general anesthesia, you see that the glucose metabolism or glucose uptake is much lower than during normal wakefulness, so about half. But if the patient then recovers to full arousal and awareness, then we see that also the global glucose uptake is back to 100%. And I'm not sure how much you have a background on patients with disorders of consciousness, but maybe it's useful if I briefly describe the different states that we can disentangle using FDG-PET. So first, we have patients who are unresponsive in the unresponsive wakefulness syndrome. So these are patients who show eye opening and therefore are different from a patient in coma, but they do not show any signs of behavior or conscious behaviors. For example, they do not show response to command, but they will show, for example, auditory startles. You see that these patients show a global decreased glucose uptake throughout the brain. And from what we've seen so far, you might think that consciousness is kind of on and off process, right? It's either we see that consciousness is present and global metabolism is high, or consciousness is absent and we see that the global metabolism is low. But now if we have a closer look at the same patient who recovered consciousness after being in the unresponsive wakefulness syndrome, we see that there is not so much increase in this global glucose metabolism, right? So this is a patient that is now in the minimally conscious state. And as the name implies, the patient shows some minimal signs of conscious behavior. For example, visual pursuit or response to command. But we do not really see this huge increase in global glucose uptake, but it is localized in a specific network that is important for consciousness. And I will show that again in more detail later. But it's also good that you know that even if consciousness is localized, or conscious processes are usually localized in a specific network, also the global brain metabolism can be useful to identify different states of consciousness. So here we see the metabolic index on the y-axis, and this is a kind of semi-quantification of the glucose metabolism as obtained from the FDG-PET scan. So in the unresponsive wakefulness syndrome patients, you see that glucose metabolic, or this metabolic index as a proxy for glucose metabolism, is low. MCS patients, so patients who recovered some signs of consciousness but are not able to functionally communicate, that's important to know, we see that they show a slightly higher glucose uptake at the global level. Also here in these images above, you can see that indeed there is this higher glucose uptake as compared to truly unconscious patients. Then when patients recover further, so they are able to either functionally communicate or use an object in a functional manner, then we say that they emerge from the minimally conscious state, so EMCS. And again, also this metabolic index is slightly higher. And we can actually disentangle especially the unresponsive and MCS patients by setting a threshold on the metabolic index. And any patient with a global glucose uptake below the threshold is likely to be unresponsive, and patients with the glucose uptake above the threshold are likely to be in the minimally conscious state. And of course, there are some patients for who this threshold did not work, right? So here we have some patients in the unresponsive group, and they actually have a higher glucose uptake. And indeed, these patients actually did recover consciousness at follow-up. And for the patients in the MCS group that had a glucose uptake below threshold, they also usually had a worse outcome. So if we then translate this metabolic index to the percentage of glucose uptake as measured by SUV, then we can see that the threshold for which we can disentangle the two patient groups is at 42%. So if the global glucose uptake as measured with SUV is lower than 42%, then the patient is likely unconscious. So this is the way that you have already seen that Ariana plotted some SUV images. This is the way that we do it. Just a small recap. So in MRI Cron, we use the color scale NIH, and we scale the values between 0 and 12. And then you see that for healthy controls, there is this high uptake throughout the brain. MCS patients much lower, but still some preserved uptake, and unresponsive patients show really much reduced glucose uptake. And so that's true at the global level, but we know that we have to consider more specifically the glucose uptake in this network, that is the frontoparietal network. So that's what Aurore Thibault and Rajanikant Panda, two colleagues of the team, have shown in a recent paper in Annals of Neurology. So here they compared the behavioral diagnosis that was based on the observed behavior as measured with a standardized behavioral test, and they compared it with the FDG-PET scan, and more specifically with the SUV, and they looked at the glucose uptake in this frontoparietal network specifically. And then if you combine these two ways of diagnosing patients, you can identify 3 groups instead of 2 groups that we had based only on behavior. Namely, you see that there is the MCS patients that also show behavior of consciousness. Yeah, they usually show this glucose uptake that is relatively high, and indeed the two diagnostic tools are in agreement, and we can conclude therefore that the patient is minimally conscious. Then you have the other group, the unresponsive patient group, that we can divide in 2. The first group shows no behavior with behavioral assessment tools, but also shows this very low glucose uptake basically throughout the brain. And we can therefore conclude that such a patient is indeed really, truly, or most likely truly unresponsive. However, actually the biggest part of the patients who are unresponsive at the bedside show a glucose uptake that is relatively preserved, or it is higher than what we would expect if the patient was truly unresponsive. And these patients are termed minimally conscious state star. So even if there is no behavioral evidence for the presence of conscious awareness, there is some cerebral activity that is most likely able or shows a capacity for consciousness. And it is for these patients, of course, very important to get the right diagnosis, because outcome and also treatment choices will depend on such a diagnosis. So here we can look at 3 cases. So they are 3 patients who all suffered from, I think, anoxia, yes. And they were all 3 unresponsive at the bedside. So with the coma recovery skill revised, they were assessed. This is the CRSR, the standardized scale to do the behavioral diagnosis. They were all assessed several times, at least 5 times, and in none of the 5 assessments they showed any sign of behavior. Also, if we look at the preserved SUV uptake in those patients, you see that it is relatively low. At least it is lower than the 42% threshold that we have seen before. And also all these patients had a bad outcome. Either they remained unresponsive or they died in the following months or years. And yeah, it's quite clear from the SUV map that glucose metabolism is globally very low, and that the PET scan confirms the diagnosis of unresponsive wakefulness syndrome. Then we can have a look at 3 MCS patients. So these patients, well, 2 of them had a traumatic brain injury. One was an anoxic patient. So the anoxia patient groups, or the patients with an anoxic etiology, they are more often unresponsive actually, and the patients with the TBI are more often MCS, but of course you can have some exceptions to that, as you can see here. So these patients were assessed with the coma recovery skill revised as well, at least 5 times, and they were all 3 able to show signs of behavior, of conscious behavior. Also, if we look at the global SUV, we see that it is preserved above the threshold of 42%. And also the outcome, well, these patients remained the same, in the same level of consciousness, but they did not die. So it's relatively better than the patient groups or the patients that are truly in the unresponsive wakefulness syndrome. And then we can have a look at 3 MCS star patients. So none of these patients that were all assessed with the CRSR, they showed any sign of behavior. So only reflexes were observed. But then if we look at the preserved glucose uptake, as measured with the SUV, we see that it is above, for these 3 patients, it is above the threshold of 42%. Also, if you look at the images, you see really that it looks quite different from the first patients that we saw, where we could basically see only a very blue uptake, so across the whole brain. And one of these patients actually recovered to also show behavioral signs of consciousness after the PET scan, and 2 other patients, they died. So I think from the SUV image, it's kind of clear that you can really use it as a diagnostic tool, and that the visual assessment is very useful to identify different states of consciousness. So here we have on top the healthy control group with high FDG-PET uptake or scans or glucose uptake. And this is also confirmed by high connectivity across the whole brain. Then if we look at the MCS patients that also show signs of consciousness at the behavioral level, we can see that the FDG-PET scan shows some preserved glucose uptake, right? And this is again confirmed by the EEG. So EEG is another neuroimaging tool that we use in our team to complement the behavioral assessment. And usually it's a good sign when we see this functional connectivity, especially long-range functional connectivity from the front to the back of the brain. And indeed, even if it is lower in these MCS patients, it's lower than in healthy controls, it's still relatively preserved. Also, the outcome of the patients in the minimally conscious state is relatively good. So either they remain in the same diagnostic group, or they can also recover consciousness. And about 1/3 of them has a bad outcome. But then if we look at the unresponsive patients again, we see that there is this group of patients that is actually the minority of the patients that are unresponsive at the bedside. So a minority of those patients also shows glucose uptake that is very much reduced, and confirms the diagnosis at the behavioral level. And also you see that those patients show very low functional connectivity and also have a bad outcome. So half of the patients remains in the same state, and half of the patients dies at 1 year follow-up. While if we look at these minimally conscious state star patients, So patients that do not show behavioral signs of consciousness, but show FDG-PET scan that is more in line with what we would expect for a minimally conscious patient. We see that this is confirmed with the electrical activity that is measured in the brain, and these patients also have a better outcome as compared to the true unresponsive patients. So using, we can see that about 1/3 of these patients improve level of consciousness at 1 year follow-up. So yeah, I think that's it for the SUV part.